Thank you. It's a pleasure to be able to talk to you about the REMAP-CAP trial. This is an international platform trial that was designed specifically for a pandemic. We've been studying interventions in standard community-acquired pneumonia in the interpandemic period and have switched now our interventions to COVID-19. With additional funding from the NIHR, we've become UK-wide and one of the CMO's priority platform trials. And this international trial was designed to generate evidence to reduce mortality, ICU use, and morbidity in the most severely ill patients with COVID-19. REMAP-CAP is an acronym that builds on a number of important design features in the trial. A lot of proposals have been put forward for how to treat this novel disease. Some may be correct, but unless we randomize, we won't learn. If we rely on observational data only, no matter how large its size, there will always be the serious limitations and we will be limited in the causal inferences that we can make. Working in a pandemic is hard, and so we knew the trial needed to be embedded into normal clinical care, so that it was easy to include and randomize a patient, but also the patients included needed to reflect real-life situations, so we've made sure there are very few exclusion criteria. And similarly, we don't just compare one drug. The patients will need to be treated multifactorially, where we can simultaneously assess different aspects of their treatments. So antivirals may play a role on their own in the community, but other treatments will be needed for sick patients. Do steroids help by reducing inflammation? Or in fact, do they increase viral loads? Can we modulate the host immune response to the virus that we know causes so much morbidity and mortality in these patients? What about antibody therapy, whether that be convalescent plasma or maybe in the future monoclonal antibodies against the virus? And we've seen that thrombosis is a major problem in COVID-19. So what is the best strategy to manage anticoagulation in this group of patients? It's an adaptive trial. We use a Bayesian design, and compared to the more normal frequentist statistics design, it gives us more flexibility. So in a traditional trial, you would select a sample size based on expected effect size and recruit to that. Whereas we recruit patients and run regular interim analysis where we will declare a drug as either being superior, inferior, or equivalent when it hits predefined statistical triggers, and these triggers have to be predefined. So we announce the result as soon as one becomes clear. We also use response adaptive randomization. So the randomization ratio starts equal, and then at an interim analysis, if one treatment is seen to be potentially beneficial, the randomization weights in favor of that treatment. This is repeated at the next interim analysis, and if it's still looking favorable, more patients are randomized into that treatment, so that by the time you get to the end and have an answer, more patients are already receiving the treatment. So patients recruited later in the trial learn what is the best treatment based on patients recruited earlier in the trial. So a sort of self-learning healthcare system, which we think is important in a pandemic. And the final letter is P, it's a platform trial. So people come into the overall platform, and then each of these individual domains, as we're calling them, is almost like a mini trial within the overall platform, with one shared primary outcome, which is the number of days alive and free of ICU support for each patient. Our inclusion criteria for the platform are straightforward. Are you an adult patient admitted to a critical care area due to COVID-19 and you require some form of organ support? That can be high-flow nasal oxygen or CPAP. And if you're not using those for infection control reasons, then you're still eligible at that time if you would normally have used it. We want to recruit patients early in their critical illness. And our only exclusion criteria is if death is deemed to be imminent and at the same time you're not for full active treatment. Here you can see the multiple domains and multiple interventions that we're testing. So in the antivirals, Kaletra, hydroxychloroquine, and the combination of the two. We have a number of questions about how to use steroids early in the disease. And in the immune modulation, we have interferon beta 1a. It's been proposed that may help the immune system fight coronaviruses and also attenuate acute lung injury outside of COVID-19 as well. Anakinra, an IL-1 receptor antagonist used in rheumatoid disease and also in macrophage activation syndrome, which is thought to have an overlap with COVID-19. And then we have tocilizumab and saralimumab, two IL-6 receptor antagonists, looking to see if we can reduce the inflammatory response in COVID-19. The immunoglobulin is currently looking at convalescent plasma, and there'll be more about that in a moment. And managing anticoagulation. Should it be a prophylaxis dose, maybe an enhanced prophylaxis dose, or is it better to use full therapeutic anticoagulation? It's a very modular trial. You don't have to take part in every intervention, and you don't have to even take part in every single domain. And this can be turned off for individual patients as well, depending on inclusion and exclusion criteria. When you randomize a patient, you get allocated one treatment in each of the eligible domains, and you can see you could therefore get a whole multifactorial treatment regimen recommended for treating this patient. So very few patients will get no new intervention designed to tackle COVID-19. This has been a whistle-stop tour through the trial. If you want to read the full protocol, it is published online. How have we done? I think, well, as a critical care trial compared to a ward-based trial, we're never going to recruit the tens of thousands of patients, but you can see we've recruited virtually 550 patients, and the vast majority have come from the UK. And I think that reflects the fantastic critical care research community that we have in the UK, and also the fact that the NIHR have supported these platform trials and prioritized them. It's been a team effort, and I want to thank all of the team, both at Imperial and ICNARC, who've been working together to deliver the trial. Also, all of you working on the front line, delivering the research, but also the clinical care. It's been tough for all of us, a real challenge, and I thank you very much.